Okay, what is uterine inversion? Uterine inversion is dipping of the fundus of the uterus in the uterine cavity, and it occurs because we have given undue traction on the cord. Undue traction मतलब बहुत ज़्यादा traction है ना. During the third stage of labor, we have not managed the third stage of labor properly. It requires rapid diagnosis and rapid management. Otherwise, it will lead to maternal mortality. So here this slide is, the inverted part is this, and it is cupped by the obstetrician, and we are trying to push this part, है ना. तो जो सबसे बाद में पार्ट आया यूट्रस का बाहर, उसको सबसे पहले अंदर करना है. ये इसका प्रिंसिपल होता है. The diagnosis. How will you make a diagnosis? Clinically, you will find that the patient has a lot of pain, and during in an attempt to remove the placenta, the patient suddenly develops a lot of bleeding and a lot of pain. You keep a hand on the abdomen, you cannot feel the fundus of the uterus. Fundus is not felt per abdominally. Per vaginally, you will feel that there's a lot of bleeding, and mass can be felt either in the vagina or through the cervix. Also inside the uterine cavity you can feel a mass, and you are not able to understand anything, and the patient is sinking. She's going into shock. यूट्राइन इन्वर्जन में एक तो पेशेंट ब्लीड कर जाती है, तो हाइपोवोलेमिक शॉक डेवलप हो जाता है उसको, और दूसरा इतना पेन रहता है कि उसको न्यूरोजेनिक शॉक भी हो सकता है. और शॉक का मतलब ये है कि वाइटल्स फॉल होते हैं, बीपी एकदम कम हो जाता है, लो, टैकीकार्डिया हो जाता है, और पेशेंट जो है वो कॉन्शियसनेस लूज करने लगती है. तो इमीडिएटली उसको जो है इंटरवेंशन की जरूरत होती है. अल्ट्रासाउंड इज ओनली यूज्ड टू मेक डायग्नोसिस ऑफ क्रॉनिक इन्वर्जन केसेस, है ना. अक्यूट इन्वर्जन में इट डज नॉट गिव सो मच ऑफ टाइम for you to use ultrasound. Now here, the first degree uterine inversion ये वो होता है जब जो फंडस, तो फंडस की लोकेशन क्या है उस बेसिस पे इसकी ग्रेड्स होते हैं. तो अगर मान लो कि ये यूट्रस है और ये फंडस जो है ये कैविटी में है, ऐसे डिपिंग हो गई है. बहुत ही खराब ड्राइंग है मेरी, तो पार्डन मी फॉर दैट. ये फंडस है, ये अंदर आ गया. In the cavity it is lying. This is first degree inversion. When this fundus reaches up to the cervix, this is second degree. When the fundus reaches in the vagina, it is third degree. When the whole of the uterus and the vagina are outside the introitus, it is fourth degree uterine inversion. Okay. The main complication is कि बहुत ज़्यादा bleeding हो जाती है और patient shock में जाने लगती है. तो जो है हमको फटाफट इसको as early as possible you have to diagnose, and you have to reposit the uterus. The earlier you reposit, the better the chances of success of reposition, and the duration, the more the duration that passes in between, तो फिर दिक्कत हो जाती है रिपोजिशन में. क्यों? क्योंकि सर्विक्स का इन्वॉल्यूशन स्टार्ट हो जाता है, और सर्विक्स एक कैसा रिंग बना लेता है, एक रिजिड सर्वाइकल रिंग इज फॉर्म्ड which stops the uterus from repositing. Then you have to deal with that ring also. So earlier you reposit, the better are the chances. What are the causes of uterine inversion? Fundal attachment of the placenta. So placenta is attached to the fundus, and you are pulling on the umbilical cord, है ना, in order to remove the placenta, and the fundus gets inverted. The uterus is atonic. In 40% of the cases, it is uterine atony. Either it has been due to prolonged labor, or it has been due to the use of magnesium sulfate for a long period of time, or it was a case of twin pregnancy, or it was polyhydramnios, okay, or that you have not given any oxytocic or any agent to contract the uterus. So it will lead to, and you are pulling on the cord, it will lead to uterine inversion. Sometimes the cord is very short, and normal amount of traction also will lead to inversion. If it is placenta accreta, what will happen? The placenta has entered inside the myometrium. It goes deep, passing the endometrium, it reaches up to the myometrium, and now you are pulling on the cord, है ना, but still over time it is not able to separate. Then if you make an attempt to give excessive traction, then what will happen? It can cause inversion. Okay, So the main principle is that the part which comes out last has to be pushed first. You don't have to remove the placenta. If you remove it, it will cause more bleeding. So if you want to remove, of course you want to remove, you will remove it after you have reposited the uterus back. And give bimanual compression after reposition and start her on oxytocin infusion so that the uterus remains contracted. So the principle is that you have to treat hypovolemia. You have to get her recovered from the shock. If you find that the cervix is not allowing you to reposit the uterus back, then you can give some uterine relaxant like terbutaline or magnesium sulfate or isoxsuprine to relax the uterus first. And then what you will do? After that you can reposit. So quickly you reposit and you succeed. Sometimes months after the happening, patient comes to you with a very large uterus, swollen, edematous uterus lying outside the uteritus, and a mass can be felt. She has lower abdominal pain, she has foul discharge from the mass, and she has chronic malaise and low backache. And when you see, you confuse it with prolapse of the uterus. When you examine, get an ultrasound done also, you will find that the uterus is missing. And she has a history which suggests you that it can be uterine inversion. Then what you have to do? So you have to apply some hygroscopic agents on the surface of the uterus. You have to give her antibiotics for broad spectrum coverage. And once it shrinks down, then you can perform hydrostatic pressure technique for reposition. Static pressure, you will put some water-filled balloons inside the vagina and you will keep the patient in Trendelenburg's. Trendelenburg's is 15-degree head down tilt, and that balloons which are filled with water, they are placed in the vagina and they will apply pressure on the fundus of the uterus, on the most dominant part of the inversion, and it will gradually it can push it back to its normal position. That is hydrostatic pressure. Once you are not able to correct it with this method, then you have huntingtons or haultains. Now what is huntingtons? It is a method which is performed after laparotomy. After laparotomy, you will place clamps on both the round ligaments either side. Near the insertion on the uterus, you will place clamps on the round ligaments and you will pull it. You will pull it up so that the uterus can be lifted back through the cervical opening up to its normal position. If you are not able to do this successfully, the uterus does not come out on your traction on the round ligaments, then you have to give an incision on the posterior aspect of the cervix. तो ओपन जब करते हैं तो हमको सिर्फ सर्वाइकल रिंग दिखाई देती है, और सर्वाइकल रिंग दिखाई देती है, यूट्रस तो अंदर रहता है, इन्वर्टेड रहता है. सपोज लेप्रोटमी पे ऐसा, ये एंटीरियर एब्डोमिनल वॉल है, ये पोस्टीरियर है, ठीक है. तो ऐसी सर्वाइकल रिंग दिखाई देती है, तो हम यहाँ पे पोस्टीरियरली इंसिजन देते हैं सर्वाइकल रिंग पर. उससे क्या होता है, सर्विक्स ही तो वो पार्ट है जो यूट्रस को वापस नहीं आने दे रहा है, तो फिर वो डिपॉजिट हो जाता है. दिस इज हाल्टेंस. अनदर प्रोसीजर यू हैव that is known as Spinelli's. Spinelli's is a procedure in which you enter inside the vesico-uterine space and you give an incision on the cervix from there, and the same way the uterus will get back to its normal position. So thanks for watching.